Hi, my name is Liz Mayer, and I would like to welcome you to my Nursing 348 Evidence-Based Practice and Nursing Research Project. I work at Upstate University Hospital on 9E, which is a step-down neurology unit, and the purpose of my project is to assess whether the Johns Hopkins or Hendricks Fall Risk Assessment is more effective. We just recently implemented the Johns Hopkins Fall Risk Assessment over the Hendricks Fall Risk Assessment with little explanation, so I'm hoping to get some more information on why we would have done this. There are a few quotes that I found that really address why falls are such an issue. Falls are the most common adverse event reported in acute care settings. They prolong hospitalization, increase cost of care, and have the potential to cause serious injury. Along with that, fall-related injuries are the most common cause of accidental death in those over the age of 65 and result in approximately 41 fall-related deaths per 100,000 people per year. And based on the data from 2000, total annual estimated costs were between $16 billion and $19 billion for non-fatal fall-related injuries and approximately $170 million for fall-related deaths across care settings in the community. Falls are completely preventable, which is why these statistics are alarming, and anything that we can do to prevent these costs and these injuries and deaths is going to help our facilities. My PICO question. My population is 9E step-down neurology patients. My intervention is the prevention of falls. My comparison is Hendricks versus Johns Hopkins Fall Risk Assessment. And my outcome is to decrease the falls from 2 falls in the last quarter to 0 falls in the next quarter. For a full PICO question of will using the Johns Hopkins Fall Risk Assessment instead of the Hendricks Fall Risk Assessment in 9E neurology patients decrease the falls in the quarter to 0 from the 2 falls we had in the last quarter. My background questions include what are statistics that prove them to be effective? What are some of the components of each of the screening tools? What are the differences between the two? And which is proven to be statistically better? My search process consisted of 9 steps. Step 1 is the development of my topic, which included comparing the Johns Hopkins and Hendricks Fall Risk Assessments. Step 2 is the creation of clinical questions, which I included the PICO question and also the background questions. Step 3, searching for evidence via databases. I found all of my sources on the Nursing Reference Center Plus. Step 4 was using keywords like fall risk, fall assessment, fall, Johns Hopkins, and Hendrick to get relevant articles and journals and sources. Step 5 was the use of inclusion criteria. The inclusion criteria I used was research 2011 to 2016, humans, and evidence-based. Step 6, I ruled out all the exclusion criteria sources, which included sources that had greater than level 3 evidence and sources that were earlier than 2011 and not US based. Step 7 was to verify the evidence was valid. I did this by researching levels 1, 2, and 3 of researching and making sure that all the sources that I chose were either 1, 2, or 3. Step 8 was the creation of a search table, which is on the next slide, where I highlighted that out of the 51 sources, I only chose 3 sources. And step 9 is to gather my own clinical evidence. I gathered my own clinical evidence through my nurse manager, where she sent me a spreadsheet of all the falls in the past year per quarter of each unit in the entire hospital. This is a copy of my search history table. As I said before, I used the Nursing Reference Center Plus for all my sources. Using my inclusion and exclusion criteria, I received 51 sources, but only used 3 of these sources. This is a table of the evidence that I gathered. I used 3 sources, and the criteria included sample characteristic size, design patient selection, intervention, finding and conclusions, levels of evidence, and also the strengths of the article. I concluded from the data of the 3 sources that neither the Johns Hopkins or Hendricks tool are more effective than another. Unfortunately, there were no sources that actually compared the 2 fall risk assessments face to face. So it was hard to compare the 2. The Johns Hopkins is a little bit more extensive than the Hendrick, but it does not make the Johns Hopkins more effective than the others. So therefore, the results were inconclusive on deciding whether or not the Hendricks or Johns Hopkins fall risk assessment was more effective. According to the data that I found, there was an inability to conclude whether the Johns Hopkins or Hendricks fall risk assessment was better. The plan is to revise the fall risk assessment so that each assessment is tailored to patient population. The rationale for this recommendation, there was no best fall risk with the research that I found. All the fall risks, including the two mentioned above, the Hendricks and Johns Hopkins, are very different and have both positive and negative aspects. Some other evidence is from the time the Johns Hopkins fall risk assessment was implemented in October in my institution, some units like mine have decreased fall rate from 2 to 0, while other units like our cardiac ICU have stated a steady 1 fall before and after, while our labor and delivery unit increased from 1 fall to 2 falls. This shows that fall risk assessments should be tailored to the patient population and have specificity between whether a patient's having neuro, cardiac problems, GI, surgical, etc. The IRB does not have to be involved because there is concrete evidence that there is no best fall risk assessment, which is why the individual fall risk assessment should be implemented throughout the hospital. I decided to implement the protocol using Cotter's model for change, which includes 8 steps. First step is establishing urgency, the second step is creating coalition, the third step is developing vision, the fourth step is communicating vision, the fifth step is empowering action, the sixth step is generate short-term wins, the seventh step is consolidate gains and produce more, and eighth step is anchor approaches. Establishing urgency, which includes data collection and providing statistics. Some of the statistics that could be provided would be earlier on in this presentation. Creating a coalition. Bring these statistics and the data collection from the hospital to shared governance meetings on each unit. For example, shared governance at Upstate is on each unit, and it's where nurses, HCTs, LPNs, etc. can go and talk about what they think is going well in their unit and what needs to be changed. Between the neuro units at Upstate, 9E, 9F, and 9G, we could develop a vision by collaborating and then come up with an individual fall risk assessment. 9F could come up with ICU criteria, 9E could come up with step-down criteria, and 9G could come up with floor criteria to provide the best fall risk assessment specifically to neuro patients. Then we would communicate our vision to other nurses, nurse managers, and the nursing researchers for the hospital, and better complete the fall risk assessment and research to find the best practice. Empower the action. After we were confident that the fall risk assessment is good to go, we would pilot the protocol hospital-wide, or at least neuro, to see if this would decrease the falls, and then possibly create individualized fall risk assessments for the other units like cardiac, GI, surgical, etc. Generate short-term wins is the next step. It's important to celebrate every day without a fall. Consolidate gains and produce more. Each success builds on another success, so we need to keep encouraging the team to succeed, for our patients and for our staff, and for the hospital itself. Anchor approaches. Keep using the protocol how it was intended. Make sure that we remind nurses of the benefits of this practice and the patient outcomes. The nurses will be required to fill out a new fall risk assessment every 24 hours. It's important to also reinforce the staff the prevention of falls and some of the cost statistics that are very important, and that there's incentive to do the assessments. After implementation of 1 month, it will be required for the staff to fill out a brief survey to get the views of the staff on the new fall risk assessment. Also, after a month, a statistical spreadsheet will be created to see if the number of falls has decreased, increased, or remained the same after 1 month, and reevaluate the fall risk assessment as needed. Practice change sustainment. Sustainment is a very difficult thing to get nurses to do. A lot of nurses want to be set in their own ways, and it's hard to change. Some things that we can do are we can show the staff that statistics are getting better with fall rates as we've implemented the new fall risk assessment. Along with that, we can look through the patient charts weekly and acknowledge the staff that is keeping up on the fall risk assessments per 24-hour policy. In the break room, a wall of stars will also be created for every day without a fall. You could also offer competitions hospital-wide. For example, like the unit could, with the least amount of falls per 1 month, could earn a pizza party. There's a lot of evidence and research put into falls, but it's really difficult to figure out the right fall risk assessment for each patient. I believe that if you find the right fall risk assessment per patient population, falls can be completely prevented. Thank you for listening to my project.